Greetings. Welcome to session 3 of the Pediatric Roundtable series with the Lurie Children Center for Cancer and Blood Disorders. In this session, we will introduce you to Dr. Sonali Chaudhury, and she will discuss the advances in curative therapies for non-malignant blood disorders. My name is Chaudhury. I am your moderator, and I am the Lurie Children's physician liaison for the city north and northwest suburbs, and I'm joined by my liaison colleagues, Paula Nowak and Julie Kochbrenner. But before we move on, I'd like to tell you a little bit about the Lurie Children's Center for Blood Disorders and for Cancer and Blood Disorders. We treat more children with cancer and blood disorders than any other hospital in Illinois. And although cancer is rare in children, we treat 220 new patients each year. We are ranked #1 in the state of Illinois and ranked in the top 10 nationally by U.S. News and World Report. And we treat patients at our main hospital, and then our outpatient centers in Arlington Heights, at Central DuPage Hospital, Lake Forest Hospital, Northwestern Medicine Proton Center in Warrenville, and then in New Lenox, Northbrook, and Westchester. And then before I turn it over to Dr. Chaudhury, I'd like to remind you that this session is being recorded. We encourage your engagement, so please ask questions. Just type them up in the Q&A section or in the chat room, and then after the presentation, we will ask your questions, and so they can be addressed. I want to remind you this session is being recorded, and we will send you the link after it's done. So, furthermore, if you do want to ask a question live afterwards, you can raise your hand and we will ask that. So without further ado, will you go ahead and take the screen over, and it'll be all yours to go. There we go.
All right. Good morning. I hope you can hear me well. I'm Sonali Chaudhury from the section of stem cell transplant and cellular therapy in the division of Peds Hemonc, and I've been given the daunting task of presenting advances in curative therapies for non-malignant blood disorders in 25 minutes at 7:30 a.m. So just briefly, as an overview of pediatric non-malignant disorders, we can categorize them in 4 major categories of inherited or acquired bone marrow failure syndromes, including idiopathic aplastic anemia, hemoglobinopathies such as sickle cell disease, thalassemia, metabolic or storage disorders, including leukodystrophies, mucopolysaccharidosis, and immune system disorders, including immune deficiency, as well as the more recently described disorders of primary immune regulation. Basically, non-malignant blood disorders, the only curative therapy is stem cell transplant or a replacement of a non-functioning hematopoietic stem cell. And while there are supportive care measures to improve the outcomes, such as chelation, really the one and only cure is transplantation. And the goals of transplant in these disorders vary based on the disease that we are trying to cure. It might be cessation of clinical events such as veno-occlusive crisis and sickle cell disease, produce a deficient enzyme such as in the metabolic disorders, stabilization of organ damage, which we see in the iron overload syndromes with hemoglobinopathies, reconstitute immunity as we see in immune deficiency or dysregulation, restore functioning hematopoiesis, as in bone marrow failure or idiopathic aplastic anemia. And the ultimate goal is to allow for optimal growth and development, prolong the lifespan, and provide an improved quality of life. The main feature that is different in non-malignant disease curative therapies is the use of non-myeloablative or reduced conditioning regimens, which allow to achieve a stable or a mixed donor chimerism, because eradication of disease is not the goal in many of these situations. There is no role for graft versus leukemia, which we have in the malignant setting, and this leads to prolonged immune suppression therapy in these patients. At Lurie Children's, about 50% of our transplants are transplants for non-malignant disorders. And this is an example from 2018, which sort of illustrates that. The slides at the bottom show you the improvement in outcomes for, if you look from the left to the right, it's improvement in outcomes for all non-malignant diseases in the middle slide, and aplastic anemia on the left, and immune deficiencies on the right. And as you can see, outcomes in these cases approach about 80 to 90% overall survival. How have we achieved these improvements in non-malignant diseases? There are some non-transplant criteria, and those are improvement in newborn screening. So as you will all know, newborn screening, especially in the state of Illinois, has allowed for early identification of SCIDs, metabolic disorders leading to earlier transplants prior to the onset of organ damage. And in addition, there's strategies for optimal disease control with improved supportive care, in that there's better management of iron overload, for example, normalization of inflammatory markers that we can now measure in immune disorders, enzyme replacement therapy that can be initiated early for less organ toxicity. And there's also better control of pre-transplant infections, including the potential generation of viral cytotoxic T lymphocytes in some cases if we need. What about the transplant strategies that have led to improved outcomes? We've developed novel disease-specific transplant conditioning regimens, as opposed to using an overarching single regimen with targeted doses of busulfan, novel agents such as tirasulfan, and targeted doses of ATG or anti-thymocyte globulin. Newer agents such as abatacept are used to prevent graft versus host disease, and we also have been able to allow for transplantation of non-related donors, with improvement in our alternative donor strategies, with the use of post-cyclophosphamide for haploidentical donors. Improvement in HLA typing has led to identification of more appropriate donors, and graft engineering and manipulation approaches have also decreased post-transplant complications. A novel approach, as you all know, is really the onset of gene therapy. Gene therapy is a newer strategy to cure non-malignant disorders, and this gene therapy really can be two ways of doing it, depending on the type of mutation. If there's a loss of function mutation, then DNA or mRNA supplementation can fix that, and usually this is a virus-mediated particle that is introduced in. But for a dominant negative or a gain of function mutation that causes the disorder, you really need invalidation or correction of the mutant allele by CRISPR-Cas9 or genome editing tools. The corrected gene therapy product can be introduced in vivo or ex vivo, and that depends on whether the tissue that you are trying to correct is a self-renewing tissue or a non-renewing tissue. In renewing tissues, most of the approaches are ex vivo, and that's what we are going to talk about more today. And in vivo approaches, which are used in certain metabolic disorders, we're really not going to address as much today. So moving on, I was hoping to talk about the curative therapies in 4 major categories, starting with hemoglobinopathies, and starting with the role of allogeneic transplant in hemoglobinopathies. Transplant is accepted as standard of care in thalassemia before the development of iron overload. And it is also accepted as a standard of care of severe sickle cell disease. However, the issue here is that severe or symptomatic sickle cell disease is less clearly defined. And that is why there are no universally adopted indications for transplant in sickle cell disease. Optimal timing of transplant is as young as possible, and data shows that transplant outcomes are superior if they're less than 12 years in sickle cell disease and less than 6 years in transfusion-dependent thalassemia. Conditioning approaches in transplant, as I said, have morphed over time to achieve adequate engraftment while reducing toxicity and the goal of preserving fertility and decreasing late effects. Donor sources, where matched sibling bone marrow donors are preferred source of transplant in most disorders. Less than 20% of patients will have access to a matched sibling donors, but we do use alternative donors such as match unrelated and haploidentical donors in the setting of clinical trials. Bone marrow source is the source of the stem cell graft, is the preferred source of the stem cell graft, and gene therapy are newer therapies using autologous stem cells applied for these disorders. So going to transfusion-dependent thalassemia, over the last 40 years, outcomes in transfusion-dependent thalassemia has significantly improved. And you can see that for young donors with matched sibling or match-related donors, outcomes are over 90%. With improvement in overall survival and event-free survival, we still noted that patients did have some graft versus host disease, chronic graft versus host disease, and a lot of patients persisted in having long-term morbidities. To decrease these long-term morbidities, advances in the field led to reduced intensity conditioning regimens with the goal of preserving fertility. With these reduced intensity conditioning regimens, utilizing both matched related bone marrow as well as cord bloods as stem cell sources, you can say that we were still able to maintain overall survivals of 80 to 90%. However, unfortunately, these patients, even with the reduced intensity conditioning regimens, continued to have gonatotoxicity, especially infertility at later time points, which led to the development of gene therapy trials or autologous stem cell, which are modified with lentivirus. Here, I'm going to talk about the Bluebird trial, which we did conduct here at Lurie Children's. And the process of the trial is collection of stem cells mobilized from a patient using GCSF and pyrexapore. These cells are then sent to a central manufacturing for lentiviral transduction, cryopreserved and tested, and then released back to our center. Once the cells arrive at the center, patients start busulfan myeloablative conditioning. So this is again back to high doses of chemotherapy that we use in these patients, and patients then receive the Beti-cell or a lentiviral modified product. The point of this is to transduce stem cells and reconstitute red blood cells, in this case with the hemoglobin A, which is derived from Th7Q, which is normal hemoglobin and replaces the non-functional hemoglobin in these situations. The first study had a 2-year follow-up, and a 13-year long-term follow-up study is ongoing. In terms of results from this study, I'm just going to show you briefly one of the most recently presented data. It has Beti-cell, which is now FDA approved only as of late last year, was used in 63 patients with thalassemia, and the trial in the phase 3 did go down as low as 5 years of age. As you can see, in this, there were about 7 patients in the phase 3. There were about 4 patients that did not undergo transfusion independence, and in the phase 1 and 2, it was about 7 patients, which led to change in the manufacturing process. However, overall, in these patients, more than 70% or 80% of the patients did achieve transfusion independence with up to a 7-year follow-up. There was stable gene therapy derived hemoglobin A, especially the hemoglobin T87Q. There was demonstration of reduction of ineffective erythropoiesis and iron overload in patients who achieved transfusion independence. And most importantly, especially in the thalassemia group, there was absence of drug product-related adverse events for greater than 2 years post-infusion. And there were no cases of malignancies described in this group. Moving on to sickle cell disease, I do apologize for jumping around, but I am short on time. So indications, as I alluded to, the indications for matched sibling donor transplant are more frequently accepted and usually are stroke, previous acute chest syndrome, any CNS event, pulmonary hypertension, severe iron overload. However, in the unrelated or haploidentical donor setting, where transplants are usually done in the setting of a clinical trial, the major indication for transplant is either stroke or a past history of acute chest syndrome. Transplant in sickle cells, just to briefly talk about you with matched sibling donor transplants, again, similar to the thalassemia group, was successful. However, matched siblings are not available to over 80% of the population, and myeloablative regimens, as I described earlier, did lead to gonadotoxicity. This led to the development of reduced intensity conditioning with overall survival and event-free survival of about 90%. However, unfortunately, even though the survival was extremely good in the matched sibling donor setting, even the reduced intensity conditioning did not lead to preservation of fertility and led to the development of a chemotherapy-free matched sibling donor transplant, where overall survival in this group is 100% and event-free survival is about 70%. And in this group, early results do point in the favor of preservation of gonadal function. Given the improvement in results or ability to cure sickle cell disease with matched sibling donor transplants and results of transplantation with the matched unrelated donor group also improving, reduced intensity conditioning, matched unrelated donor transplants were offered to severely affected sickle cell disease patients. This led to expansion of the donor pool, and we ended up in that group with, however, in that group, we did end up seeing significant amount of chronic GVHD, which led to modification of the matched reduced intensity conditioning regimen arm with addition of a new agent called abatacept that I described, which is approved for prophylaxis of graft-versus-host disease in malignant diseases. With addition of abatacept, we continued to see an overall survival of 100%, and we were very happy to see that we did not see any extensive chronic GVHD at 1 year post-transplant. The availability of unrelated donor transplants is still expands the donor pool. However, about 60 to 70% of patients do not have an appropriate match. And for these patients, the only curative regimen that in the setting of allogeneic transplant was a haploidentical donor transplant, which almost every patient would have. Continuing on the reduced intensity conditioning with expansion of the donor pool, haploidentical transplants were attempted in this patient cohort, and results initially were promising in that overall survival was 100%. However, there was a high rate of 45% of graft failure, but no graft versus host disease. This led to modification of the conditioning regimen with addition of a small dose of radiation or diatepa, and ongoing clinical trials in pediatrics are available at our site, but more recently, the graft failure rate has been significantly decreased with an event-free and overall survival approaching 95 to 100%. What about gene therapies? Similar to the thalassemia, lentiglobin was used for sickle cell disease. There are multiple ways of doing it, gene addition or transfer by either lentiviral-based vector or gene editing, as I described, using using downregulation of BCL11A and mimicking hereditary persistence of fetal hemoglobin. This was a landmark paper that talked about the efficacy of lentiglobin, which is a bluebird-derived lentiviral product for sickle cell disease. And as you can see in this group, in about 50 patients that were treated for sickle cell disease, by the end of 3 years, most of their hemoglobin was derived from the gene product and remained gene product derived. Also looking at the severe veno-occlusive events as a mark of functional assessment post-gene therapy, the number of veno-occlusive disease significantly decreased after 6 months following the gene product infusion. While these results are promising, the main drawback in this case was 4 cases of AML MDS were reported with lentiglobin for sickle cell disease. After being studied by the FDA, no cases of insertional mutagenesis was described. However, the risk of clonal hematopoiesis in this setting is continuing to be studied. So what about our experience with hemoglobinopathies at Lurie Children's? We've participated and led multiple trials, thalassemia, sickle cell disease with unrelated donors, the abatacept trial with the unrelated donors, as well as the haploidentical transplants donor trials, as well as the SUN trial, which is the chemotherapy-free approach. In addition to the stem cell transplant trials with alternative donors, as well as novel approaches to sibling transplantation, we've also participated and are currently participating in multiple gene therapy trials with either the viral vector or the CRISPR-Cas9 strategy. Moving on to primary immune disorders and the role of transplant in primary immune disorders. Again, in this group as well, as you can see, allotransplants have an outcome of about 75 to 80%. And this outcome is superior if siblings with matched sibling donors, and much worse with mismatch related or mismatched unrelated donors. And the reason for this decline in survival with matched versus mismatched donors is the presence of acute GVHD. Talking about gene therapy trials in primary immune deficiency, the first trial for gene therapy was over 25 years ago in ADA SCID with gamma retroviral based correction of SCID. However, this was one of the cases where insertional mutagenesis led to the development of T-cell leukemia, leading to halting of these trials. However, with lentiviral strategies, there are ongoing trials in multiple immune deficiencies, including ADA-SCID, X-linked SCID, Artemis-SCID, and Wiskott-Ulrich syndrome. Our transplant experience here at Lurie Children's is that we developed a novel reduced intensity conditioning regimen containing busulfan, fludarabine, and ATG using matched unrelated, matched sibling, as well as mismatched unrelated donors, and showed survival rates of 80% for the overall group. We modified our conditioning regimen slightly, and as you can see, with modification of our conditioning regimen, survival in our patient group was exceeded 90%. And we have this trial with this novel transplantation strategy open, and long-term outcomes here show normalization of immune studies, no evidence of late organ toxicities, and normalization of neurodevelopmental outcomes. Metabolic disorders, the role of allogeneic transplant in metabolic disorders is based on the principle of replacement of tissue macrophages with normal bone marrow-derived monocytes, and hence overcoming the enzyme deficiency. These tissues are also replaced in the brain, which are the cerebral microglia and astroglia, which is an advantage of these therapies because enzyme replacement, if available, does not cross the blood-brain barrier, and hence enzyme replacement therapy is incapable of curing the neurological defects in these patients. The standard of care is a myeloablative transplant in these patients with a non-carrier matched unaffected sibling or a cord blood. Enzyme replacement is usually continued for about a year post-transplant, and outcomes over the last few years have significantly improved with 80 to 85% overall survival. It has been widely accepted for MPS I or Hurler syndrome, and we use it frequently in patients with cerebral X-linked SCID, where transplant may arrest the neuroinflammatory demyelinating process. However, transplant needs to be performed early, and there are cases of disease progression even with a successful transplant. Krabbe's disease is another paroxysmal disorder where earlier transplant has been associated with good outcomes. What have we learned in transplantation for metabolic disorders? Full donor chimerism is better for functional outcomes, leading to the development of reduced toxicity. However, myeloablative regimens and significant number of patients do show immune-mediated cytopenia post. Gene therapy protocols are currently in phase 1-2 trials delivered either in vivo or ex vivo, and currently ongoing for MPS, X-linked ALD. Moving on to acquired and inherited disorders of bone marrow, or the bone marrow failure syndromes. On your left is a generic table of workup of patients with cytopenias. In addition to bone marrow, we send us tests for viral infections, as well as tests for detection of chromosome fragility, flow cytometry, telomere lengths. More importantly, what I would really like to draw to your attention is the role of the NGS, or the bone marrow failure panel, that we offer at Lurie Children's, which is a quicker, faster way of detecting any inherited bone marrow failures. Outcomes with matched sibling donors in aplastic anemia have been described for years, such that at present, upfront matched sibling donor transplant is the standard of care. As you can see in this figure, the overall survival with matched sibling donor transplant and immune suppressive therapy upfront is similar. However, about 60% of patients with immune suppressive therapy upfront have a recurrence or an event which shows the rationale for the offering of matched family donor transplant upfront. Given improvement with matched sibling donor transplants upfront and the decreased efficacy of transplant when it was applied post immune suppressive therapy failure, matched unrelated and matched unrelated donor transplants were offered up front. And as you can see in this, the outcomes of matched unrelated donor and matched sibling donor transplants were similar. This led to the development of a trial where immune suppressive therapy up front was compared or is being compared to matched unrelated donor transplants up front. In this graph, you can see that, again, similar to the matched sibling donor, the event-free survival with immune suppressive therapy is significantly worse compared to a matched unrelated donor transplant upfront, leading us to hypothesize that we believe that patients with idiopathic aplastic anemia with a matched related or matched unrelated donor transplant are candidates for upfront transplantation. The transit protocol is one that we are currently participating in at Lurie Children's, talking about the inherited disorders of bone marrow failure. They come in multiple groups and have poor, worse outcomes due to transplant-related mortality, leading to trials that are addressing novel agents such as treosulfan in this group. Gene therapy trials in this population are also ongoing, however, are limited by poor stem cell mobilization. And that brings me to the end of the presentation, and I'm ready for questions. Sorry,
Thank you. That's okay. Thank you, Dr. Chaudhury. That was a wonderful presentation. A lot of great details in there. And one of the questions that popped up is you brought up clinical trials several times here. So if our community physicians out there has a patient that may deem for clinical trials, how do they go about doing that? How do they find the trials?
So the clinical trials are all accessible on our website.
Okay.
Also accessible on clinicaltrials.gov with us being referred as a center, and they can contact our transplant coordinators on our website for any of these hematological disorders that are amenable to clinical trials.
Okay. And for those of you watching this presentation, if you need direct lines into the transplant coordinators, please feel free to contact your liaisons, myself, Julie Kalkbrenner, or Paul Nowak. We'd be happy to help you with that as well. Where are you seeing patients? Are you downtown? Are you at any of the other locations?
No, so for transplantation, we see patients only in the downtown location. We tend to follow these patients following transplant for about 6 months to a year. With some of our colleagues sort of on the outreach programs, we do, if patients are doing really well at about the 3-month or 100-day period, we do have the ability for some patients to be shared with the primary pediatrician and ourselves, or the primary hematologist and ourselves.
Wonderful. Well, that looks like it's about the end of the questions here. So I just want to thank you for joining us. This was a great presentation, a lot of important information that our community physicians are going to get a lot out of. So thank you so much for taking your time today to be with us.
Of course. Thank you.
All right. And just again, thank you to the audience for joining us today. And please join us later today at 12:30. Where Dr. Jennifer Rychek will discuss the caring for the child survivor of cancer. And I hope to see you this afternoon. Have a great day, everybody.